Pancreatitis is basically sudden inflammation or swelling of pancreatic gland. There are two major functions of pancreatic gland. One is exocrine functions, by means of which the pancreatic gland secretes the digestive enzymes, and the other function is endocrine function, hormonal secretion like insulin and glucagon, which helps in sugar metabolism. This is just to demonstrate you what exactly is the pancreas. As you can see in this picture, this is a pancreatic gland which is situated by the side of the small intestine called as duodenum, part 2 of duodenum, and this is the gallbladder and the cystic duct, the bile duct, which actually traverses down and then opens into the small intestine along with the pancreatic duct. So when we talk about gallstone pancreatitis, basically the stone or microlithiasis, most of the time stone, basically blocks the orifice of the pancreatic duct, thereby not allowing pancreatic secretions to come into the intestine. So this backflow causes the acute pancreatitis in patients of gallstone pancreatitis. Now when we are talking about the pathophysiology of acute pancreatitis, basically pancreatic gland secretes the enzymes protease, lipase and amylase. These proteases cause autodigestion in patients with acute pancreatitis. Basically the pancreatic gland secretes these enzymes through the pancreatic duct. It traverses into the intestine and gets activated. But in patients with acute pancreatitis, this autoactivation happens in the pancreatic gland itself, causing severe inflammation, release of cytokines and mediators, causing acute pancreatitis, thereby causing swelling of pancreas, edema we call it as when we do the ultrasound, and bleeding, hemorrhages we call it as. And this cascade of events, one after the other, of inflammation leads to severity of acute pancreatitis. Predominantly there are two types of pancreatitis. One is acute pancreatitis, second is a chronic pancreatitis. But for practical purposes, we need to define pancreatitis into four types. One is an acute pancreatitis, second is acute on chronic type of pancreatitis, third is acute recurrent pancreatitis, and fourth is chronic pancreatitis. What are the common causes of acute pancreatitis? The commonest cause is gallstone, alcohol, but there are other causes as well which affect the pancreas and cause acute pancreatitis, like drugs, pancreas divisum, abnormal origin of pancreatic duct because of embryological defect in the fusion of dorsal and ventral duct, we call it as pancreas divisum, genetic or hereditary pancreatitis, hypertriglyceridemia where the cholesterol, where the triglycerides are abnormally high, more than 1000 mg/cent, can cause acute pancreatitis. Autoimmune pancreatitis, there can be drug-induced acute pancreatitis, there can be calcium, high levels can also cause pancreatitis, we call it as hypercalcemia induced acute pancreatitis. Some rare causes are there like trauma or sometimes post-operative pancreatitis. Other common causes are viral, mumps or any other viral infection or bacterial infection can sometimes cause pancreatitis. So there are many causes of acute pancreatitis. As a clinician, we are supposed to diagnose it, the etiology of a pancreatitis or causative factor for the acute pancreatitis, so that the chances of recurrent acute pancreatitis can be avoided. One more reason of acute pancreatitis is a worm infestation, which can present with acute recurrent pancreatitis. Apart from gallstone, pancreas divisum and hereditary pancreatitis or trauma, worm infestation and drug-induced and autoimmune pancreatitis are few other causes where the patient can present with acute recurrent. I would discuss more today about acute pancreatitis. In acute pancreatitis, there are usually the severity of acute pancreatitis is decided by many clinical scores. We call it as Apache score or Ranson score or Atlanta classification. All these scores are very important to diagnose acute versus severe. But for those who want to know what exactly is the damage or what is the severity of an acute pancreatitis, we usually can, for a layman, we can say that acute pancreatitis have two types of presentation. 80% of them have mild pancreatitis and around 20% of them have severe pancreatitis. Now, what about the mortality or death rate in terms of acute pancreatitis? Approximately 20% patients have mortality, and those patients who have a severe pancreatitis, of them 30% have mortality rate. So it's basically, sometimes the acute pancreatitis can be life threatening, can put you directly into ICU with intensive care requirements, wherein you have to put the patients on ventilator and other supportive nutritional support along with the vasopressors and all, necessitating admission directly into the ICU, especially in patients who have severe pancreatitis. Those who have mild pancreatitis, they get treated with oral medications and keeping the patients on liquid or needle by mouth and antibiotics and treating the cause of the acute pancreatitis. Many times patient ask us, what is the reason in alcohol pancreatitis? How much alcohol can cause acute pancreatitis? For those who don't know, single large or single binge large quantity alcohol can also cause acute pancreatitis. It need not be necessarily the patients have to consume alcohol high intake, large quantity of intake for years or months together to cause acute pancreatitis. A single binge of alcohol is prescribed to cause acute pancreatitis. So it's advisable that those patients who have an acute pancreatitis episode, documented episode, we should evaluate them for the reason of acute pancreatitis. I was discussing about the clinical features of acute pancreatitis, where the abdominal pain, jaundice, vomiting, nausea, difficulty in breathing, we call it as breathlessness, sometimes abdominal pain which is radiating to the back in 50% of the patients. There can be distension of abdomen, there can be patient with altered sensorium. In a severe stage, we may find directly patient with fever as well. The basic investigation involves blood investigation like hematological investigation, CBP, hematocrit, amylase lipase, and other investigation like ABG, chest X-ray, and ultrasound of abdomen. I was discussing about the investigation. We do ultrasound to diagnose primarily to see the pancreatic gland, whether it's a edematous or non-edematous. We see the duct size, whether the duct is dilated, any calcification is there or not. The other finding which we can get on ultrasound is we can know about the gallstone, which is primarily the commonest cause of acute pancreatitis. Apart from that, we get a chest X-ray done to know the effusion is there, because if there is a fluid accumulation in the chest, we call it as severe acute pancreatitis. So I described the list of investigation: hematological investigation, radiological investigation. Third is in radiological role of CT. We usually do CT in severe cases, because in mild acute pancreatitis we don't need CT scan. It is diagnosed by clinical means. As far as severe acute pancreatitis is concerned, we diagnose severe acute pancreatitis by doing a CT scan 72 hours after the onset of abdominal pain, because by then we get clear idea about the necrosis and non-necrosis of pancreatitis. So when it is a necrotizing acute pancreatitis which is picked up on a CT scan, the prognosis of the patient is usually decided by the score of necrosis in a setting of acute pancreatitis. Other investigations are primarily focused on the etiology, like evaluation of calcium, lipid profile. Then we go into the details of autoimmune workup, IgG4 and other autoimmune markers we need to do. Also, we need to go into details of the drug history or trauma and other causes for diagnosing the acute pancreatitis. One of the important investigation in a setting of an acute pancreatitis, apart from hematological and radiological, as I discussed, ultrasound and CT scan of abdomen. Third investigation, an MRI of abdomen or MRCP to know the pancreatic ductal anatomy, especially in setting of pancreas divisum. Now we also have an endoscopic ultrasound, which is the gold standard for diagnosing the patients with microlithiasis or gallstone related pancreatitis, as well pancreatic collection, and then treating the pancreatic collection in a setting of acute pancreatitis. ERCP in a setting of acute pancreatitis is reserved for ductal disruptions like traumatic cause where there is a ductal disruption. In those cases of acute pancreatitis, ERCP plays a vital role. Even in patients of gallstone pancreatitis, in first 72 hours, ERCP and sphincterotomy has been proved to be beneficial in patients of acute pancreatitis. Many a times we find patients coming to us with different age groups and asking us questions. Sir, my child is only 6 years old, my son is 20-year-old, why he is suffering from acute pancreatitis. So it's very important as a clinician to keep in mind the possibility of an acute pancreatitis as per the age. As we have all discussed that those patients who come at an younger age, the possibility of a hereditary pancreatitis or an pancreativism or sphincter of Oddi dysfunction or some viral infections, these should be entertained first rather than common causes like gallstone and alcohol in such a subgroup of patients. I will briefly discuss about treatment of acute pancreatitis. Primarily, treatment is divided into two types. One is a nutritional support and second is a fluid resuscitation. It is very important that we treat acute pancreatitis severe type aggressively by giving fluid infusions in a high quantity. We give very large quantity, 200 or 250 ml per hour in first 48 to 72 hours, because that's an important indicator of outcome of a pancreatitis when you are treating. So if you give more fluids and bring the hematocrit level towards normal level, then the prognosis of acute pancreatitis is better as compared to those who are not well treated. So we talk about golden hour in heart, we talk about golden hour in brain stroke. There is something called as pancreatic stroke, where first 48 to 72 hours are very crucial, and it is this time that patient should land up in a pancreatic center where they are taken care by the pancreatologist, interventional endoscopist, a laparoscopic surgical unit, to make sure that the correct treatment is guided, supervised, and the outcome of the patient becomes better when we treat them aggressively in first 48 to 72 hours. Now, as I was mentioning, mild pancreatitis, they get treated, they get all right with support, keeping the patient nil by mouth for a few days or liquid diet most of the times, and giving them fluids, and they become all right in 2 or 3 days. But when they have a severe pancreatitis, they may need ventilatory support or ICU admissions or injectable antibiotics, sometimes heavy antibiotics, or we can call it as top antibiotic, high grade antibiotics we may require to give them for control of pancreatic infection and thereby stopping the further damage in a setting of an acute pancreatitis. Next session I will be discussing about chronic pancreatitis, the presentation, etiology and treatment of chronic pancreatitis.